Hey everyone, thanks so much for joining me on the Slice of Healthcare podcast. I'm your host, Jared Taylor. On today's episode, I'm speaking with Deepak, the founder and CEO at Ray. How are you today?
Great. Thanks, Jared, for having me on.
I'm excited to chat. I'd love we'd kick things off. You just tell the audience a little bit about your background and then we'll go from there.
Sounds good. So my name is Deepak Gopalakrishna. Maybe I'll go a bit chronologically, right? Undergrad in biology from North Carolina, and then ended up in medical school and doing a PhD in genetics, mostly because I wanted to have an impact on people's lives, right? And we'll talk about, we'll connect those dots to what I'm doing right now, I'm sure, at some point in the podcast. Did that, started a biotech company, had a small exit there, ended up in venture capital for a few years, did another tech startup, this time in San Francisco, and ended up not getting product market fit, which is actually my first exposure to that term. Ended up pivoting that to a consulting business, after which I actually met the folks at BCG, who were just getting started on a venture studio and a venture capital fund model. Joined that, was one of the early employees there back in late 2013, early 2014, and took sort of founder, CEO type roles in a number of the portfolio companies there, and did that for about 7 years or so. Left in late 2019, 2020, and started doing a bit of product market fit consulting, because in the interim, did a ton of work on that space, kind of wrote a playbook on how to get to product market fit. Lots of iterations on doing that, and lots of learnings in market, and started working with venture firms with their portfolio companies, and which is kind of how I got to where I am today. But yeah, keen to dive into that. Let me know which topics makes the most sense.
Yeah, we'll have to give a quick shout out to Plume Health, who you're an advisor of that company. And we had one of their founders on the podcast back in I think episode 67 in the 60s, which was back in October. So we'll put a link to that too, so people can check out that podcast after this as well. But yeah, I'm excited for us to chat. What I usually do with guests is we'll go through, if you give us basically the why, how, what of your company Ray that you're working on now. And then you and I have a couple topics centered around access to care, quality of care that we want to go through today. Then we'll shift focus to those after we kind of get that why, how, what from you.
Yeah, no, sounds great. I think going back to sort of why I went to medical school in the first place, right? I born in the 80s, so I guess it technically makes me a millennial, but very, very
Or a vampire, because you don't look like you were born in the 80s.
Yeah, man, it's just good genetics. Nothing else really. But yeah, so born in the 80s, when I was born, my grandmother at that point, my mom's mom, I used to, all I experienced with her growing up was, 6 months of the year, she would be in bed, and she wouldn't get up, and she would have all her meals in her room, which for me was strange. Eventually, when I got to meet other, my friends' parents and grandparents, and then the other half of the year, she would be pretty violent. And we didn't talk about mental health. We didn't talk about any of that stuff. It's pretty taboo, right? I grew up the early part of my life in India. So there's still a lot of stigma there, even now. I think that's changing in the US and in a lot of parts of the world. But yeah, that was my first exposure. And, what I found out later is that she was the top of her med school class. She was a doctor in 1950s India, like breaking all kinds of glass ceilings before, we even talked about glass ceilings, but was diagnosed with mental health issues later on in her life, and treated with heavy doses of lithium, electroshock therapy, all kinds of barbaric treatments that, and over medication that, in a lot of ways continues till today, right? We still don't have the kind of precision tools. We still don't use high quality psychological therapies. And that's what actually made me want to go to medical school in the first place. I wanted to change the way we deliver care. I wanted to, impact sort of the structural issues that existed in care delivery. So I've always had this like goal of impacting about 10 million people's health outcomes and lives. for the things that I do and the things that I bring to market. And that's been the sort of the vein throughout all of the things that I've chosen to do over time. So it's always been in healthcare. It's whether it's a biotech company or a consumer health company. I even did stuff in the crypto space, which were still tangentially related to healthcare and identity and data ownership. So that's always been, the vein that has stood the test of time. So when the opportunity to work on this rolled around, I met Daniel Freeman and the Oxford VR team probably back in early 2020, and I saw what they had, which was real clinical data on technology that could actually deliver care to people with psychosis, phobias, PTSD, anxiety. And the clinical data was astounding, right? I'd spent ages looking at digital health and digital health tools and digital therapeutics, and I just hadn't seen the kind of clinical validation with the kind of rigor that I saw with what Daniel had built, which was essentially, let's take the best minds in the world at psychological therapies, let's say psychosis or PTSD, and let's download that into virtual reality environments to create what we now call in the moment therapy, right? Which is getting treatment for fear of heights or getting treatment for social phobias should not be done in a room or in a Zoom room. In fact, it should be done on a bridge or in a lift or in a crowded bus or in a doctor's office, right? And unfortunately, we just don't have sort of economically feasible ways to do that. Like, we can't just send therapists along with people for a whole day to do this trip and do that repeatedly once a week, right? So what Daniel had built was a way to take the best minds in the world at doing this and put it into those environments and be able to give people access to that kind of high quality care. That's what got me really excited, which then allowed me to sort of really wrap my head around, what does it mean to go from where we are today, which is what I term as sort of mental health 2.0, which is we've gone from physical rooms to doing, treatment in Zoom rooms, kind of like you and I are, to what does it mean to sort of really sort of create network effects and leverage for high quality therapists and give people access to high quality therapists in the moment that they need it, but also where they need it, right? And that kind of creation of scale is what we need, because we could train 4 times the number of therapists tomorrow. We still wouldn't be able to meet the demand. And sort of newly minted therapists are unlikely that they're going to be able to deal with the complex cases at a complete load as well. So you're going to drive burnout. So for us, it's the name of the game is creating access to high quality at scale, and being able to do that in the moment, in the environment, to get people to outcomes faster. And that's what we've been able to show and publish in the Lancet, and Nature, and British Journal of Psychiatry. So that's kind of the genesis story of sort of, where I came from, what made me sort of do this. And in all honesty, sort of what I see as the biggest opportunity for us to solve some real big problems in the delivery of mental health.
Appreciate that background on the companies that you're working on and what you're building, and why you decided to really focus in on mental health. I want to kind of shift focus, but we're still going to talk about mental health. And you brought this up a little bit, right? But let's talk a little more about it. You and I were talking about this earlier, before the call, the evolution of mental health, right? And what does 3.0 look like? Can you, I guess, quickly take us through how mental health has evolved, and what is 3.0 mental health today?
Yeah, I think the most sort of simple way of thinking about it is we all had to drive in order to get mental health care. We all had to sort of show up at a psychiatrist's office or a psychologist's office. We had to drive there. We had to park. We had to go in. People would see us going in. There's big stigmas associated with that, right? So that was 1.0. You go to a physical building, you walk into a room, you see a psychiatrist, you see a psychologist, you get treatment for 40-minute session. It's talk therapy, right? That was the only modality that was available. So to fast forward to 2.0, which is kind of the world that we live in today, right? Which is You do that same thing, except you're not driving to an office. You can do it from the privacy of your own home. So maybe some of that stigma is gone, but you also have access to therapists in Zoom rooms. So that's great, but the modalities are still talk therapy. And fundamentally, the economics are still the same, right? You still spend an hour or 40 minutes, really, with a therapist, and then you do that once a week. And then the therapist spends the rest of the hour doing documentation, et cetera. To me, 3.0 is solving some of the core problems. So by 2.0 solves some access problems, right? In that, it gives us a broader pool of therapists to access who maybe don't live within 20 miles of you. But access isn't necessarily the only problem. In fact, I actually think that's half the problem. It's about access to quality and sort of being able to do that in a way that truly scales the quality supply or the quality therapists that we have to be able to see that demand. So to me, 3.0 is how do you use technology that can actually deliver outcomes by itself or decrease the cost side? And what I mean by decreasing the cost side is the biggest sort of piece on the cost side is human cost, right? It's therapist cost. So how do you scale a therapist to being able to see a lot more patients or impact the outcomes of a lot more patients? And it isn't going to come from text messages and Zoom, right? I mean, these are good tools that maybe increase access, give us some additional communication, but there's no health economics data to show that it actually moves the needle. So to me, what that looks like is a fundamentally different sort of technology chassis of digital therapeutics that can actually deliver outcomes by themselves, and where you think about it in the same way we think about human computer augmentation in other worlds, right? So the role of the therapist actually change, right? So the protocols change. So human beings do what human beings are particularly good at, right? Which is empathy, building trust. And that trust is super important in therapy because that's what has an individual commit to doing that care. So it's empathy, it's trust creation, building the care plan, and potentially dosing and titrating. But on the back end, you have the ability for people to access care through therapeutics, digital therapeutics, like virtual reality or other web and mobile-based tools, which have been proven to actually deliver those outcomes by themselves, right? And then that human computer augmentation allows that high quality therapist to be able to see a lot more people. So when we're talking about network effects, that's what we're talking about. And that to me is the big step change that is going to be needed, because there's no way we're going to scale the supply side to meet the demand. We could, 4x it overnight. And honestly, that's probably a pretty bad idea, because you don't want people directly out of school seeing sort of complex cases at a full load. That just leads to burnout. So how do you decrease burnout? How do you improve outcomes? How do you scale that high quality therapist, and how do you use technology to do that? And I think the missing component in all of this has been the technology, right? We've had text messaging, great. We've had Zoom, great. But where is the technology that can truly deliver outcomes that has been proven to do that? And I think that missing component is what I found when I started to talk to Daniel. And the virtual reality phobias and fear of heights and fear of public speaking, the ones for psychosis and social avoidance. I mean, the data on that is absolutely phenomenal. What you do is you compare that, just delivering the care fully automated in a headset to someone to control, and you see that you can get people better in as little as 2 weeks, about 4 weeks, without any actual human time. And that to me is the big unlock that allows us to move to 3.0.
Thank you for that. Appreciate it. I want to, we're coming up on time here, so I want to get through a few more things that we wanted to just talk about and really focus in on, how Ray's solving a supply side problem. And then we can kind of wrap it up with, you and I talked about this again, is access to care really the problem? And, what's the bigger problem here? Quality of care is the bigger problem. So if we can kind of tie those three things, I guess, together as best as we can, be much appreciated, and go from there. But I'm excited to hear your responses.
Yeah, no, man. Look, I think you're absolutely hit the nail on the head. I think we focus on access as the problem, and actually had an interesting conversation with Tom Insold the other day, where we both talked about this. And it's like you're only saying half the sentence, really, because it's access to quality that is the problem that we need to solve. Because if you think about value in healthcare, it's you're either delivering better outcomes or at same cost, or you're delivering the same outcomes at lower cost. And the only way to do that is by giving people access to high quality care, right? And either you get there faster by getting access to the same people, or you take those high quality people and you scale them to see more patients, and sort of you reduce the cost side. So to me, that's the problem. And that actually dovetails into how we think about the supply side problem, because the solution there cannot be, let's go find sort of newly minted graduates and just put 30, 40, 30, 35 sessions through them, right? The way I think about that is like, if you and I, when we just finished like our bachelor's, we're trying to do the jobs that we're doing now, we would not be very good at it. And in fact, I would imagine that we would probably fail pretty spectacularly at it, right? And it's just absolute madness to imagine that you can take people directly who are graduating from a program and give them those kind of full complex loads and actually expect good quality outcomes. So to us, it is, let's go find folks who are at the top of their sort of game and allow them to practice at the top of their license. And the way we allow them to practice at their top of the license is by utilizing these types of clinically validated technologies that can deliver care and sort of shift the role of the human and deliver that human computer augmented sort of care delivery. But so not only do we only focus on people who, have spent the time and have gained that experience and have really become sort of experts in their field, but we also figure out ways to not try to utilize them at 80%, 90% of their capacity, which is what is happening right now. We ratchet that back. And by doing that, we actually solve for another major problem in the space, which is provider burnout as well, right? In addition to that, we're actually looking to partner with folks who already have very successful clinics and very successful primary practices, rather than try to go down the individual sort of contractor route. So when you put all of that together, we're able to get a high quality supply side that then delivers good quality outcomes, right? Because for us, the name of the game isn't volume. It's actually good outcomes and good value.
Well, I got to tell you, I'm really excited to continue to follow the progress of the companies that you're working on and your background. Hopefully we can have you come on again real soon. You and I also talked about doing some group podcasts together with other guests that have been, maybe it's even Matthew from Plume, right? We get him on and you guys can talk together, but I'm excited to continue the conversation. It's great to have connected with you, and wish you all the best of success.
Likewise, Jared. Lovely to chat and happy to come back on anytime, especially with Matt.
Thanks.